Medic 43, District 1, Engine 51, response, cardiac arrest.
Hello, everybody. Welcome again to another edition of the MCHD Paramedic Podcast. This is Dr. Casey Patrick, and joining me today is our Division Chief of Clinical.
Good afternoon.
Nick Smith, and also inaugural first podcast for our new Assistant Medical Director, Dr. Mike DePasquale.
Hi, everybody.
So today we're going to review a recent addition to our pharmacology here at MCHD. Last continuing education back in the early fall, late summer, we introduced Ceftriaxone for open long bone fractures here in the district. And there are definitely some details worth discussing and reviewing related to our CE presentation. So that's really the why behind this discussion. We want to talk about how we pick these patients, who we pick, and most importantly, from my standpoint, the downsides that we need to avoid, where some of the potholes can be within this protocol. So we're going to open with terminology and classification. So when we talk about open long bones within the hospital from an emergency physician, really more of an orthopedic surgery standpoint, if you do a little Google search or you look at ortho bullets or you check out YouTube, you'll find folks talking about the Castillo-Anderson classification with 3+ types of long bone fractures. Not to bore you, but the small ones, less than 1 centimeter skin openings, those are type 1. Type 2 open fractures are in between there, 1 to 10 centimeters. And then the big ones, the greater than 10 centimeter, dirty, significant tissue loss, arterial injury, those are type 3s. And in the hospital, the treatment of those 3 classes varies. And some of this has varied over time, so you can look at older references that may reference different antibiotics. But for the most part, all type 1 and type 2 open fractures in the hospital get cefazolin or ANSEF. Y'all, if you've delivered an open fracture, you've heard the emergency physician or the trauma surgeon or the orthopod ask for ANSEF. Type 3 open fractures, however, the dirtier ones, the bigger ones, the ones with lots of tissue loss, classically have gotten ANSEF or cefazolin and gentamicin, but a lot of the newer recommendations allow for Ceftriaxone for class 3, type 3 open fractures, plus or minus metronidazole for anaerobic coverage. So that'll be important in a bit as to what we chose and why we chose Ceftriaxone here at MCHD. What's the evidence and what's the idea behind this? Really, it's quicker antibiotics equal less infection. That's the goal. There's a paper from 2015 by Lack that talks about open tib-fib fractures that are class 3 or type 3. And if the antibiotics are given in the emergency department at a time point less than 60 minutes from time of injury, there's less infection. So quicker wound coverage equals less infection as well. So the quicker we can get these folks to the operating room covered and washed out, the quicker we can get them antibiotics independently, the less long-term infection they have. This is a American College of Surgery trauma core measure in the hospital and the ED, so that ED doc asking for cefazolin real quickly when you roll in the hospital shouldn't be surprising because that's been pushed on us over the last 5 to 10 years. What about EMS? Does it matter? Can we make a difference? And recent data in pre-hospital emergency care from just earlier this year from the folks up at Peth, they looked at open fracture antibiotics in an EMS setting. This was in Pittsburgh. They decreased the time to antibiotics by approximately 20 minutes. And so you may think, 20 minutes, big deal. If we're on a 60-minute time clock, or at least somewhere in that range for decreasing long-term infection outcomes, then 20 minutes definitely can make a difference. Now, our service area here in Montgomery County is pretty darn large. I don't have the exact comparison between our service area and the folks at Pitt, but I would say our 1,100 square miles is probably a bit larger. And so we should at least gain 20 minutes is the way I would interpret that. And so when we look at overall outcomes, decreasing infection, saving 20 minutes plus can't be anything but a good thing for our patients. Who are we targeting, Chief Smith?
Yeah, so specifically, and for now, we are doing this for open long bone fractures only. So this is the humerus, radius ulna in your arms, the femur, and tib-fib in the legs. Not places like the face, the fingers, or the toes for now. So not at this time. Dr. DePasquale, do you want to talk a little bit about why we chose Ceftriaxone and why we're using that as our third-gen antibiotic here?
Yeah, so like Dr. Patrick just mentioned, a lot of times in the ER we'll call for ANCEF, but we can use Ceftriaxone for these type 3, more dirty, more kind of nasty, big open wounds. And so in an effort to kind of consolidate and not add too much, I think, to the ambulance, I think going with the one thing that kind of covers them all, the third generation cephalosporin Ceftriaxone, I think makes the most sense in terms of ease of use for the, the everyday medic using this. I think we've all seen the big femur sticking out of the leg from the guy who lays his motorcycle down that then rolled into the dirt, and that thing's super dirty, and that needs Ceftriaxone. Now the smaller tib fib from fall down and it's sticking out a little bit, does it necessarily need that? Probably not, but it certainly isn't going to hurt. It's definitely going to cover. It's easy to use. It's an easy vial. It's inexpensive. It's been around a long time. It's not a new medication at all. And it's something that's, I think it integrates well into what we're doing already. It's not priority number one, obviously, but it's easy to add while you're already transporting, especially when we're talking about long transport distances.
I guess just to chime in there, we did read the National EMS Physicians statement a couple of weeks ago at the time of recording that talks about this exact subject and a lot of these exact same decision point factors. There is one glaring difference in the recommendations that the national body made versus what we chose here, and obviously we made this choice before that came out, and that was cefazolin versus ceftriaxone. So there's room for conversation here, and we're not by any means saying that we're right and anyone else is wrong. We chose ceftriaxone with a purpose, and that was the big dirty ones are the ones that have the most evidence for quicker, better. So let's roll with that. More evidence, more input. We always value our national society's position statements and where the experts weigh in on these things. So we're not married to this by any way, stretch, or the imagination. But for right now, we feel like this is the best choice for MCHD.
Yeah, I'll say that also that, may have some other EMS uses in the future that we can think towards. So stay tuned for that, because we're going to talk a little bit more about that. Dr. DePasquale, do you want to talk a little bit more about, how ceftriaxone works and kind of lead into a little bit more of the pharmacokinetics of that?
I'll fall asleep over here.
Sure. Yeah. Well, while he's sleeping, briefly, ceftriaxone is a cephalosporin antibiotic. It's a beta-lactam antibiotic. And there are several generations of cephalosporins. First generation is the ANCEP, and ceftriaxone is a third generation. And as these generations go up, you wind up with broader spectrum, as they call it, coverage, with the first generation covering mostly the gram-positives, like the regular stuff, staph and strep, that causes most of the skin infections, and then the higher generations covering some other bugs that cause infection. Basically, the way it works is it just gets in the way of the bacteria being able to make its cell wall. And then importantly, what that means is that it's bactericidal, meaning that the bacteria is killed as a result of giving ceftriaxone. And I think, as Chief Smith was alluding to, there are some other uses. Kind of ceftriaxone, I feel like, is a bit of a Swiss Army knife in the ER sometimes. You order it for a lot because not only does it cover, we're talking about here with this orthopedic injuries, but it's also used frequently for kind of first line for urinary infection, urosepsis, that sort of thing, pneumonias. Importantly, it covers meningitis as it crosses the blood-brain barrier, and then, of course, a variety of ortho uses as well.
Allergy-wise, we spent some time on allergies, thinking about how we were going to teach this, because this gets a little bit dicey. Yes, cephalosporins are what I would say is a distant cousin of penicillins. From the standpoint of allergies, though, where do we fall on allergies? How do we word that in our education? How will we reinforce that to the medics? If I tell you, Doc, I'm allergic to cephalosporins. The last time I got ceftriaxone, I had anaphylaxis. You would?
Probably not give it.
I mean, unless we'd had a really bad day and he wanted to knock me off, would not give it. But in all seriousness, how did we word this? Because this was one that, when you talk about it in a global sense, it's pretty easy to say, oh, we just wouldn't do it here and we do it there. But from a protocol education standpoint, for all 350 of our paramedics and EMTs out there, this becomes probably a point that will be the biggest question we would have gotten. So how did we describe allergies to the crews?
So we try to keep that as kind of binary of the decision as we could, kind of easy and simple. So if the patient reports allergy to any kind of cephalosporin, then we're just going to withhold ceftriaxone. If they report a penicillin allergy, it's still okay to proceed with the ceftriaxone. The cross-reactivity between cephalosporins and penicillins is very low. The most notable for cross-reaction is with the first generation, and so since we're dealing with ceftriaxone, it's almost completely negligible. So even if someone truly did have penicillin allergy, and most people who say that they have that probably don't have that, even still, those people could probably still receive ceftriaxone. And you know, we've kind of asked people to just kind of proceed with the patient's best interest at mind, and to be honest with you, if they have a reaction to it in front of us, well, we know how to treat that as well.
It's the best spot in the world to have anaphylaxis in the care of good, solid emergency providers. So
yeah, and so, you know, obviously we're talking about this in the context of MCHD protocols only. But that being said, Doc, what if you're unsure? What do you do if you're unsure if you should give the ceftriaxone or not because you have an allergy concern or consideration?
I mean, I would say that if you're not sure, you can probably withhold it. I think that this is not going to be, you know, this is not epi for anaphylaxis, right? This is not an imminently life-saving intervention. We can let them sort it out at the hospital. They have certainly much more breadth of antibiotic choices there than we have.
In time, and in the end, you hit a great point, and that is short-term, in the immediate time that we're caring for these patients. This is not life-threatening, and that's really where the unintended consequences of adding this protocol came in. And that's always my biggest concern, our biggest concern when we implement any protocol, is that what are we going to get in the way of? What are the life-saving things that this is going to, you know, throw a wrench in the gears of? And so taking it back to the core foundations of trauma management really helps us isolate what are the things we can't miss. Scene time, we've got to get time to definitive care and bleeding control. We have to get the wound washed and opened and repaired. So we have to maintain scene time. We have to get access. We have to keep the patient warm. We have to get TXA on board. Those are really non-negotiables for us in that very short-term 10 to 15-minute increments that we're dealing with within that golden hour. And we can talk about the golden hour and whether or not that still holds true. And it's like everything else. It's complicated. But we don't want to be mucking around on scene waiting to get IV antibiotics in for an open fracture when the liver's busted and bleeding and needs, packed and laparotomy and IR and whatever else fancy things that the trauma surgeons are going to do. So don't get in the way of the core trauma foundations to get Rocephin on board. And at this point, we've given it 5 or 6 times. We reviewed all those charts. All of them look very, very appropriate. Scene times look excellent. TXA is on board when it needs to be. Very pleased so far with a small N value, admittedly. This has only been out in action for a few weeks, literally. We're looking at all of those charts to make sure that we don't see any of those unintended consequences. So let's review the MCHD protocol with a couple of frequently asked questions, and we'll wrap it up. You want to take the protocol, Chief?
Yeah,
go for it.
I'm happy to talk about it. So FAQs for the protocol. So what's the dose that we give? So for us, we chose a 1 gram dose. That's IV or IM. The vial that we bought needs to be reconstituted. So for us, that's 3 mLs of saline in that vial for that reconstitution. Again, this is for long bone fractures only. So humerus, radius ulna, femur, and tib fib. Not the face, not the fingers, not the toes. For peds, our dose is 50 milligrams per kilogram, max dose of 1 gram. We do not have lidocaine available for IM, sorry, but this, with time as a factor, and as you talked about for the unintended consequences, this is something that's very important to us. Few things that we were asked, because there are always great questions that we don't think about when we hold our quarterly CE for our medics when we come in and train. One question we had was, what about amputations?
It's a long bone fracture. CE gets longer by the day because the questions get better. We put these educational offerings together and look at them, and we talk about them, and then we give them to 350 people who pick them apart in a very good way and give us more educational points. So amputation was one that I got that I hadn't really thought about. We said, yeah, that's a long bone fracture by default. So obviously, when it comes to foundations, the tourniquet needs to go on before we get the IV antibiotics. If we're talking about stop the bleed here. But if we get the patient stabilized, we're on scene for 8 minutes and we're en route to the hospital with a tourniquet on an amputated arm or leg, then by all means, IV Ceftriaxone is within protocol.
The icing on the cake, yes. What about, Doc, for traumatic arrests?
Those patients are not alive, and we want to try to reverse the causes of traumatic arrest in general, and so that's not going to be an open fracture. That's not causing them to be in cardiac arrest. Now, we do want to get an airway, oxygenate and ventilate, get access, and get a fluid challenge. We want to make sure that we straighten long bones, bind the pelvis, do those traumatic arrest resuscitative points that we do in everyone. Stop the bleeding if it's external would be the fifth point. But that bone sticking out, getting antibiotics is not going to resuscitate or save anyone. So in this situation, because I know that somebody out there listening is saying it to themselves, well, what if we get ROSC? If you get ROSC and you have a lot of extra time on your hands.
Congratulations.
Congratulations, first off. Congrats to the patient. But I really would not be overly consumed with that. I would be fixated on oxygenation, ventilation, keeping the back of the truck warm, and getting the patient to definitive care. Does that get us to take home?
That wraps us up into take-home points.
Anything you want to add before we take it home, Dr. DePasquale?
No, I think that pretty much says it. I don't think anyone's priority, even after you get to the ER with this ROSC traumatic arrest, is going to be calling for ANSEP.
No, that would not be the first order of business. So that's really all tongue-in-cheek aside. The message here is prioritization. And yes, decreasing open fracture infection is a priority, but it's not a priority above scene time, above blood pressure,
bleeding
oxygen,
control.
end tidal, and the things that we deal with every day so well. And honestly, we feel like we do a good enough job here with trauma to allow us to add this icing on the cake. That was probably the place we started with this protocol, is can we do this? How well are we handling our bad traumas, and can we add another facet? And we believe we can, as long as we stick to these take-home points. The dirtier the fracture, the quicker the antibiotics, we believe the better the outcome. That's the reasoning behind this. For long bones only, for now, arms and legs, humerus, radius, ulna, femur, tibia, fibula. If in doubt, treat. We don't want to treat skin knees. Open fractures can be difficult. Sometimes there's a question of whether or not that deformed forearm and that puncture wound are contiguous. And so if the deformed forearm is near the puncture wound, then treat it as such. If there's an abrasion at the elbow and the wrist is deformed, that's not open. That's not continuous or contiguous. If you have a cephalosporin allergy, no go. If you have a penicillin allergy, feel free to give Ceftriaxone. If you're concerned and it's a medication you've never heard of and you're like, is that a cephalosporin? I don't know what that is. I'm not really sure. Then by all means withhold and allow the emergency department to give the antibiotic like they have been for eternity. Mind your trauma foundations, scene time, access, warmth, TXA, rapid transport, good hospital communication, and handoff. 1 gram dose for adults, 50 milligrams per kilogram for our kids, up to that 1 gram dose. So everybody 20 kilograms and under will get a weight-based dose. 20 kilograms and over will get a gram. So that's where your cutoff would be. So if you get a kid that weighs 100 pounds, 90 pounds, 80 pounds, you're going to be at the adult dose down to 20 kilos. Use hand-heavy here at MCHD. No conflicts of interest. We are a hand-heavy service. But just for those medics out there that want to know what's behind the hand-heavy, it's 50 milligrams per kilogram, 1 gram after 20 kilograms in weight. As always, if you have questions, ideas, thoughts, criticisms, please email us podcast@mchd-tx.org. Follow us wherever you listen or watch. If you're watching on YouTube, sorry you have to watch us, but folks out there do it, so follow us. subscribe. Send us a good like or a review wherever you can. We appreciate positive feedback. If it's negative feedback, sleep on it and make it nice in the morning. Otherwise, you hurt our feelings. Thanks for listening. Thanks, Chief Smith, for joining us. Thanks to Dr. DePasquale for making your inaugural but not final show on the podcast. We're happy to have him. Happy to have the help. Excited for what the future will bring. Thanks for listening. We'll talk to y'all again soon.